Okay, good afternoon everyone. I'd just like to start by thanking Marie and others for their invite this afternoon. I suppose just an observation from being here with you today is I very clearly see there's some overlap in our different presentations today, and I suppose I can see that there's been a change, and Karen and I just reflected on this briefly. I think there is definitely a momentum. There's momentum between looking at heart failure and thinking of palliative care. Probably in the last couple of years, I'd say the last 4 to 5 years has seen significant change, and that is important. I think that's to be celebrated, and I also think it's to be pushed on and pushed forward. And we hear about tools such as the palliative care assessment tool and other work and the challenges that we do encounter in terms of caring for these patients. It is important that we think that we are striving and working together to take things forward. I entitled the presentation around earlier integration, and I think that's been a key theme that you've heard again throughout today, is about upstream. So we think about palliative and end-of-life care, and it's important to think about embracing palliative care and the palliative approach much earlier on. But the focus of my presentation today is thinking about carers and actually thinking about, we've heard about patients, we've heard about all decision making and about ICD and different forms of treatment and treatment preferences, but also what about the needs of the carers of these people and the importance to actually think about their care. Again, I'll just go through this very quickly. You've heard all of that in terms of a major public health issue. We know about the demographics, we know about the prevalence, all of those issues that are there in relation to our population, people with comorbidities, living longer, all of those things you've heard over and over today, and the challenge that that brings with it. And we know that it is a life-limiting condition and that it does have significant symptom burden, and we've thought about the different symptoms that have come through, the clinical symptoms, the dyspnea, all of the fatigue and all of the pain and the other aspects, and you've heard that today already. And also about the trajectory. We know about the uncertainty, we know about the difficulties in prognostication, and we were challenged about that this morning and thinking about how we actually use that and get so specific in our disease related thinking that you can have a sudden death, and you've seen the different patterns in relation to comparatives of cancer and then the slow decline for heart failure. So we know though that's the situation. I want to flag up a recent piece of work that looked at the palliative and end-of-life care research priorities that this is undertaken within the UK, and we also have this undertaken within Ireland. And the difference here was that this was undertaken with patients and users and carers and their families and practitioners. So it wasn't with researchers, so it wasn't people like myself sitting saying this is what I think is a research priority. It was with users and carers, but one of the key messages that are coming through is the need to focus on palliative care and non-malignant and also carers. So that gives a rationale for actually really taking stock and thinking about carers in the whole situation. We know that the World Health Organization has called in their recent documents and in their legislation about earlier integration. And again, our previous speaker had flagged up the idea of looking, whenever you had the example within the States, about the earlier integration and the importance of palliative care for all systems, all levels and all conditions. And that is a huge challenge. Yet when we think about the services, we know that palliative care services are underused for heart failure patients. And again, it's interesting to think about our challenge. I think it was Karen had talked about direct and indirect. And you know, the importance of thinking it's not to suddenly say that we have all referrals and we have specialist palliative care for everything. But again, if we think about a palliative approach, we think about palliative care within primary care, within other settings, within generalist settings, the idea of thinking about direct and indirect and getting our idea right about the balance within that. Within the palliative care literature, we know that informal carers and supporting carers is a clear research priority. We know that whenever we look at the evidence base, it was a top research priority for supportive carers. We know that some of the evidence would suggest that carers are also socially isolated, financially disadvantaged, have an impact in terms of their own anxiety and depression, and also in times can have needs equal to, if not more so, than the patients. So that's an important factor to think about. And also the whole caregiving burden. The idea when we think about we've heard about the idea of diet, we've heard about anorexia, cachexia, all of those symptoms and the pain. A lot of the times the person who is working with and supporting the patient who has these symptoms is the caregiver in terms of physical support, but also in enabling them to have self-care and manage their condition. So it is important to think about the needs of the carers. So I want to report on a study that we've been undertaking in All Ireland that's looking at the quality of life and the palliative care needs of people living with heart failure and their carers. So some of the objectives were to undertake a systematic review of the literature, and particularly focusing on the psychosocial needs of the carers, to look to identify patients with advanced heart failure and recruit eligible patient-carer dyads, to evaluate dimensions of inequality in carers and relate this to the patient's symptom profile and the carer's quality of life, burden, level of preparedness for their role, and then to look at exploring their experience of current and bereaved carers. So our research design was a sequential confirmatory mixed method study, and you can see the different phases there that we have looked at. So we had various quantitative measures. I'll talk about some of the findings that we have there. And we also had a final phase, and we're still finishing off our final phase in bereaved carers, but we undertook some qualitative interviews with current carers in both North and South of Ireland. So from our systematic review of the carers' needs, and this was published in the European Journal of Cardiovascular Nursing, were 3 areas of support needs that were identified. Psychosocial support needs to maintain a sense of normality and normalcy in their role. Very much support around the daily living, so the very much practical daily living activities. And then they needed support to navigate the healthcare system. And then constantly their needs were continually being prioritised and reprioritised depending on the patient's level and their stability. So depending on how their clinical situation was and their clinical condition was and their medical condition had an impact on how their needs were continually reprioritised. But that there was a need to have a holistic approach that would support the carers, and this was very much incorporating heart failure and palliative care, which is the essence of around what this seminar today is really actually looking at. In relation to the study design then, as I've said, it's an all-Ireland study, so we had to secure ethical approval for both the North of Ireland and also in the Republic of Ireland. The study was adopted by the Northern Ireland Clinical Research Network, and part of the process was that we have to, and I'll talk about some of the learning because I think it's maybe interesting from Phyllis's presentation this morning, I came in towards the end of that, but it's about we screened the heart failure databases to look at identifying eligible patients and the importance of thinking about your inclusion and exclusion criteria and deciding on what group of patients you actually want. From that then, once we identified our eligible patients, then the contact was made with the research team, and we needed that from an ethics point of view. We had caregiver packs, but if you think our focus was on the carers, we had to really access our carers through our patient population. There's some debate in the literature that you can actually talk about trying to access carers direct, but from an ethics point of view, that is difficult, but I know colleagues in the UK are trying to tackle that and actually get directly to carers if that's what your focus actually is. Then we emailed out the questionnaires, and the patients and carers returned it back. And then we had an opt-in phase around looking if they would be willing to take part. That came back separately to say if they'd be willing to take part in an interview. Some of the lessons learnt in terms of our challenges that we really encountered very early on was our database and our database retrieval and identification of patients. Whenever we started this out, we were told that there would be, so we did our power calculation, we tried to see what our sample size would be, we worked off a database of what we were told what the numbers were, and yet when we came to actually interpret and interrogate the database, a lot that wasn't accurate. A lot of the patients had actually subsequently died. There was different records of how people recorded and maintained their databases, and not all sites stored it electronically as well. So there was issues around the identification of the patients that we wanted for our sample. And that the heart failure teams document clinical information quite differently as well. So in terms of the NIH scale and everything, and there was a level of interpretation needed to see if patients met our inclusion criteria. I'd like to talk about the inclusion criteria as well. And again, we've had the discussions we've tied it through where you talk about NIH level 3 and 4, and that's what we wanted. And yet physically and mentally suitable for us, they needed to have a carer because that was the focus of what our study was about. Then also we had our ejection fraction Interesting to hear the debate earlier on today about how that was derived and what leads all of that. And then they had to meet one of the other following clinical criteria. So whenever we had our discussion with our cardiologists and with our team around trying to identify people who we would consider as quite advanced heart failure, we had these clinical parameters that were introduced. We did have our hospital admissions, we did have our IV diuretics, and we did have BNP. It's interesting if you think about that in relation to the gold standards framework and other maybe palliative care criteria that could be applied as well around the surprise question. We didn't use that. We went a lot with the clinical criteria, but it was actually difficult and there was issues around identifying our sample. But in looking at a database of One Electronic that we did have, we would see that approximately 14% of the patients on a full database met this inclusion criteria for the study. Then our method of recruiting caregivers. So you always talk about gatekeeping within research, but we had two levels of it. So we had gatekeeping from the health professionals who would sometimes, despite the inclusion criteria being there, would interpret their own criteria or interpret that criteria in a certain way and apply other criteria. Just not today. Things are not great. We just won't apply it, even though the patient would have met it. But then the patients also would identify gatekeeping, whether they wanted their relative to be informed or know about the study as well. So there was two levels there because our method of recruitment. So all of this just makes, in terms of research, it makes it challenging. You have to come up with alternative solutions, but you have to recognise the reality of undertaking this type of work. So looking at our tools in our pack then, you will see that we had different measurement tools. The top four were very much tools that we collected data for both the patients and the caregivers. So one around health questionnaire, PHQ, which is a measure for depression. And this was like from, moderate to severe to none at all to moderate to severe. Measure of anxiety. And again, you've heard other tools that were mentioned today. We had the level of perceived social support, and that was a scale again, it's a 14 item. And then the Minnesota Living with Heart Failure, and there is a carers edition and a patient edition. It's also a clinical tool you can use in practice, but we had using it here obviously for research, but it gives us a level of quality of life. Self-care, which was for the patients, where they identified around the maintenance, management and confidence of their self-care. It was 3 dimensions within that. What their beliefs were about their illness for the patients. And then for the caregivers, looking at their burden, their perceived level of burden, their perceived preparedness, how prepared do they feel to undertake this role that they have, and the Care Support Needs Assessment tool, which is a tool that has been developed. It's also an intervention developed around care support needs assessment intervention. So there is also an educational component developed by Gun Grand and colleagues in the UK, but we use this for the purposes of actually identifying what the support needs that the patient or the carers would see within the study. Just some results then in relation to our response rate. You'll see that generally we had a response rate based on around, for the patients, 56% overall. I've compared this with Northern Ireland. You can break it down, you can see the difference between Northern Ireland and Republic of Ireland. But 56% of the patients had returned the questionnaires and 49% of the caregivers. Some of the demographics, again, if I want you to focus on the carers here as opposed to the patients, but what we've seen earlier is that most of our carers were female, as you would expect given your patient population. The age range was quite diverse, so we had some carers from the age range from 35 up to 89, so we had an average there in terms of mean age was 64. Interesting, the educational level, and I think it was some of our previous presentations today in thinking about the educational and the reading age that we talk about. We did have quite a few of our population of our carers who were educated to university level. Now, we could critique this, we could critique about some of the limitations and do they actively reflect what we would expect of the carer population. It could have been the sites where we recruited, there's a lot of issues within that, but it's interesting to note our population in terms of if you think of their education, their socioeconomic status and some of those other factors that we initially thought about in terms of inequality and dimensions of inequality, because this fits within a framework for social justice, the original project. So that is important for us to tease through. But the majority of our carers were also spouses. I just want to draw some comparisons between the patient and the caregivers around the measures of depression and their quality of life. And it's probably not really a surprise that you see here that in terms of the scores that were statistically significant were around the levels of depression. So if the patient had a higher level of depression, the caregiver also did. And the same with if the quality of life of the patient was poor, this had an impact on the caregiver's quality of life. Some of the other important things to tease through were the patients were more depressed and they had poorer quality of life. The heart failure had a greater impact on the physical quality of life when compared to the caregivers. Age was an important factor, so the younger caregivers was associated with much poorer outcomes in terms of depression, anxiety and quality of life for both the patients and the caregivers. So if it was for a younger person, it definitely had a difference. And this also came through in our qualitative, where we found that older people in some of the qualitative interviews would not even see themselves as a carer. This is just what I do. I've been married to this person for 50 years. This is my job. I'm not a caregiver. I'm a wife. I'm a husband. This is what I do. I think also an important thing, there was a positive correlation with depression and anxiety on both the quality of life for both patients and caregivers, is what you would expect. And more than half of the patients identified as having an inaccurate knowledge of their condition. They seen themselves, they didn't fully understand, and again I think it teases through some of our discussions around when we talked about deactivation, earlier conversations, they didn't really understand their condition. They had an inaccurate knowledge, and this was self-report, they identified their survey of their beliefs, they seen it as inaccurate. However, this didn't have an impact on the care outcomes. There was a significant negative correlation between patients' self-care score. So if patients were poor in terms of looking after themselves, then the carers had increased depression and anxiety. And the patients had managed their care better, so they had better self-care whenever they did have interactions with healthcare professionals. However, if they had an awful lot of appointments, then this had an impact on their quality of life. This decreased the quality of life. And that came down to, when it came in the qualitative interviews, the sheer effort of trying sometimes to get to outpatient appointments, lack of coordination around going and getting there and getting physically into the hospital. So there's something about managing the level of contact and having that to improve self-care management and keeping an eye, as we might like to think, in terms of healthcare professionals, but yet not making that overly burdensome. So I think there's something around where that sits in the management, and the caregiver's anxiety score predicted their caregiver burden. In terms of the levels of depression, there was significant levels of depression for nearly 50%, about 40% of the carers had levels of depression and anxiety. So again, we have our focus around patients and families, our patients, and we know anxiety and depression, you'll see from the previous presentations today, and because of the symptoms and the symptom management, but there are significant levels of depression for the caregivers as well. Also, 23% reported having poor support. They didn't feel that they had support. And that a third of the caregivers perceived their quality of life to be poor. And they also had mild to severe levels of distress. Also to note the time that they spent caregiving, the 53% of the population spent over 20 hours a week doing household tasks, 60% working with their loved one, and 50% were attending medical appointments. So in terms of the time component that caregivers, it's an important aspect to also consider. Impact, it had an impact on their own quality of life whenever the patient was more depressed and anxious. Whenever the caregivers were caring for someone with a reduced quality of life, they themselves experienced greater depression and anxiety and perceived burden. They were more likely to be depressed and anxious when the self-care abilities were down and were reduced for the patient, and the patient depression contributed to their burden. And caring for a loved one with heart failure had less impact on the caregiver physical, their own, whenever they did have high levels of social support. So if they had other levels of social support, the physical element of their quality of life didn't have as much impact as whenever the other elements. In looking at the support needs, Well, one of the key aspects of the support needs that came through was all this focus about the future. So we talk about planning for the future and thinking about future. Also, 50% were concerned with dealing with their own worries and their own feelings. And 26% would like to get a break from caring overnight. And the younger caregivers, again, significantly more help in dealing with financial, legal and work issues. Level of distress was associated, I've sort of talked about that, and that the caregivers felt with more support, they would feel more prepared for their role. Then we moved towards the qualitative interviews. So really the purpose, with some key findings, we know that the caregivers had high levels of depression and anxiety themselves, that for the younger caregivers it was an important aspect to be considered, that their perceived levels of looking at their preparedness was impacted on the patient's self-care ability and also the anxiety and depression of the patient. And we also know their support needs were very much around looking at thinking about future planning. So really the purpose of these interviews were to look at current carers and to have some more in-depth about what their experience really was and to understand it and to actually see what their factors they think could help them in relation to support and factors that would assist them in development. So we had an interview schedule with purposive sampling, so we wanted to make a judgment to have geography, north and south, but we also wanted to have a variety of relationships, so spouse, daughter, sister, those sort of different sibling relationships, and also gender as well. And the qualitative interviews were transcribed and were analysed using NVivo, and we looked at themes and codes. And I just want to give you a brief view on some of these. One of the important things was the context of caregiving. So it very much came through around the context of their role and very much the 24/7. It's 24/7. And they feel that they cannot get away and move from that. The emotions that were there, I think there's some strong words coming through there in terms of panic, hopelessness, fear, anger, all of the emotional aspects around the emotional roller coaster that they experience, and that the life they felt was ruled by the patient's condition. So I don't have a life, my life is sitting in a chair watching. And that is the strength of some of those quotes, I think, is very important to think out, that all of the things about their role, about trying to support them. Then one of the other themes was looking at the service provision. So I think, again, we've sort of talked about trying to think about our services and what we offer in relation to, we're thinking about transitions between specialist palliative care and heart failure and a whole general palliative care approach. So the improved service provision is having this idea around planning for the future, that they want to know about what to expect. Continuity and coordination of care. So they feel, and again, with increasing population who have comorbidities and the difficult and anxiety that causes you, not just between, so if you have someone who's got rheumatoid arthritis or who has got something else or who's seen by the geriatrician or who's seen by somewhere else, that they don't feel anybody speaks to anybody, and actually the difficulty in navigating that and continuity and coordination. And then transitions of care. Now this is a particular example of transitioning from home to community, but also again, if we think about between services and whenever they reach points of reaching transitions from one part to the next, it is the difficulty that the carers actually experience thinking about this. And the importance again about information to empower. I think again we've heard about empowering the patients to make the decisions, giving them information. The same resonates for the caregivers as well, to help them, to help the care. We've talked about patient-centered care, and that's all our ethos, and we've mentioned informed consent, but also family-centered care, and to think about the role of the carer within that too. Their support needs were very much around the emotional aspects. Somebody else to talk to who's similar position, knowing when to get help in terms of a point of contact, triage, having the information to know when do I make that phone call, when do I not, is it the time to go to the hospital, is it not? And then I think fundamentally a lot of this, and we've heard that continuously again today, about the importance of communication. The communication to enable better relationships between the actual patient and the family, and also with the wider healthcare professional team. So importance of that. Please finish. It's 4 o'clock on a Friday. Just some conclusions then. I think the importance of focus on the future and anticipatory planning is important. We've talked about, and you've heard, earlier integration and the transition of care. There is a need to develop a supportive intervention and feasibility. So we actually have secured funding. That's the next piece of work that we're moving to, is to develop an intervention and looking at the components of an intervention, probably largely focused around psychoeducational for carers, but we're going to move to that next year. And I'd just like to acknowledge my colleagues on this. And finally, I will give an advance notice of a possible hold your date. If you're interested, we are planning to have an evidence into practice workshop, largely to present the findings of this, but more to take it and inform how can we get this into practice. So advance notice if you're interested. That's the person to contact, Leanne, postdoc researcher, and maybe just put a wee notice in your diary if you're interested. Let me know. Thank you.